Good morning, everyone. Nice to see you. Sebastien Rhodes. I lead the business strategy and operations functions for a company called Triomics. So the core mission of what we've been doing at Triomics is taking the latest advancements in generative AI and bringing them to the field of oncology. And so what that looks like for us is a core engine. We call that core engine OncoLLM, oncology-focused large language model. It's not a singular language model, but rather a constellation of models and a really robust pipeline of coordinated efforts to accurately, efficiently, cost-effectively extract key data elements from all of the different disparate data sources that we have for use in downstream use cases. So on top of that core engine, some of the use cases and the workflows that we have touch on clinical trial matching, patient chart summarization, data curation. But it turns out that once you have a really good understanding of the longitudinal history of a patient, there's a lot of things you can do. And it's really just about configuring that information into the existing workflows of whatever problem it is that you're trying to solve. So why have we kind of attacked this problem, and why is the kind of engine I just described organized in the way that it is? And it's really because, as almost I'm sure everyone in this room knows, that specifically in the field of oncology, the mass amount of data and the mass amount of key data in the that we need to make decisions for our patients exists in these unstructured formats. And so unstructured, for those who may not be familiar, really just means information that is not readily machine readable. It's not something that I can search on. And so what that creates is this need for manual chart review. And so whether you're a physician in this room, a nurse in this room, another provider in this room, an administrator in this room, that means that you spend an outsized portion of your time flipping through patient charts, trying to look for something to solve a problem for you. And luckily, with the advancements that we've seen with language modeling and generative AI, a lot of that can be taken away. And so we have all of these different unstructured sources here: progress notes, pathology reports, imaging reports, all of the things that may exist within a patient chart. But even beyond that, think about things like our guidelines, our pathways, our clinical trial inclusion and exclusion criteria. All the things not only are we trying to understand from the patient chart, but the things that we're also understanding that patient chart for downstream. And so the problems that we'll discuss today and the problems that we're trying to address as a business is really rooted on the thread that exists across all of them, is this idea that manual chart review can be, maybe not eliminated, but drastically reduced with the advancements in some of these technologies. So, this is what we're working with today. We got really complex scanned PDFs. Some of that information, can be in one document. It can be spread across multiple documents. You may need multiple documents to make a single inference. And then just to do all of that, we're trying to match that information to these trial inclusion and exclusion criteria, which are becoming more and more complex by the day. Amazing that we have the personalization of medicine, that we're getting better treatments for our patients, but that means we have these concatenated inclusion and exclusion criterias, and we're going down to the nth degree to what it means to be eligible for some of these trials. So how do we think about how we've built our stack and how we address this problem holistically? So the base layer is, Jason, as rightly mentioned, it's all about data access. Data, your models are only as good as the data that you have access to and the data that you give it. So thinking about, direct integrations into EMRs that we have with every single one of our customers. We think about how can we make sure that we're working with the document management systems of certain organizations to make sure we're getting access to all of the scanned records, the PDFs, things that are coming in from Care Everywhere, other HIEs, other sources, trying to create the most robust and holistic understanding of that patient record as possible. Then we have this kind of middle layer, this oncology reasoning engine. So this is where we've kind of taken the advancements in generative AI and brought it over to oncology. And so we've provided it this context-aware knowledge, this multi-step clinical reasoning, the same way that you as a physician or a clinician or a nurse or a provider would think about going step by step if you were manually doing this problem. We have built that same reasoning, that same step-by-step thinking into our pipeline and process. So instead of leaving a singular model out there to go about their own wits, we've really chunked each and every single step of this problem down to ensure that the model is forced into the way of thinking that we know that our end users would be doing it if they were doing it manually. And then, the output of this layer becomes really this structured understanding of your patient. So now we have things like, disease, staging, biomarkers, treatment history, regimens, this really, base layer of who is this patient, what am I looking at? From there, what we're able to do is pump that into a bunch of different workflows and use cases, as I was mentioning earlier, where once you understand the patient, it's just a matter of understanding the workflow that you're trying to address, and can I take that information that I understand about that patient and feed it in appropriately into workflows that fit into the day-to-day of our end users. Trial matching is one I'm gonna cover quite a bit today. Cover off on some of the data curation and feasibility pieces a bit, but there's a lot of opportunity here, as Jason mentioned, starting to look at tumor boards and a bunch of different pieces, and it's really just a matter of, can we really critically understand the workflow? We feel confident that we have the data now to support those workflows, but can we make sure that when we put the workflow into place, it's actually saving time, it's not adjusting the way our end users are working? So before I get into some of the nitty-gritties, what we've been up to, how this has kind of worked in practice, did a lot of early on publications, peer-reviewed journals, Nature, ASCO, really important. We thought, over the last 2 to 3 years, as everybody in this room has been rightly skeptical of the adoption of AI, doing this in a way to build the utmost confidence. Did a lot of those kind of research and publication heavy efforts early on, and have now kind of led to deployments at some of the largest cancer centers in the country, MSK, MD Anderson, Mount Sinai, Yale, Michigan, Indiana, a bunch of community practices, our partnerships with US Oncology Network, and now kind of expanding these capabilities out of the traditional large academics into the, and taking some of these capabilities to where more than 80% of our patients are being seen into the community as well. So I'm going to double click now into kind of our flagship workflow, the clinical trial screening process. So the first paper we wrote on clinical trial screening published in Nature was this idea: can the model, completely unassisted in an automated fashion, accurately identify a patient's trial eligibility across an entire portfolio of studies? And so we did this paper in conjunction with our partners at Medical College of Wisconsin and Mount Sinai, and looked at their entire their trial portfolios and a random set of patients. And then we had their expert users, clinical trial nurses and coordinators and research managers, verify the outputs of this model. And we were able to find that the model, in a completely automated fashion, was able to accurately match those patients to trials that they were in fact eligible for 95% of the time. And this paper's over 2 years old now. We probably closed the gap on that 5% a good amount. But another thing Jason mentioned in his talk, it's not good enough to just have a black box that spits out this patient is eligible for this trial. We need the ability for the AI to explain itself. Why did it make those inferences? But even more than that explanation, we don't want an explanation that's in a black box either. We want citations of that explanation back into that patient record. If I need to, as a human, verify down to the nth degree, is this a right justification? I need to be able to do that. And so we also evaluated the capability of the model's accuracy on its explanations, as well as its accuracy on the citations it used within those explanations to make certain inferences on inclusion-exclusion, also above 90%. So the platform is called PRISM. It has a few different main workflows. The one that I think for anyone who has either used trial matching software before or been familiar is this middle bucket, trial to patient matching. I feel this is how, up until kind of some of the advent of Gen AI and LLMs, this is really how technology was looking at the sphere of trial matching. I have a trial. I know I need to enroll patients for it. I need to go out and search and find patients for this particular trial. All well and good, but we end up in a workflow where when we do some of that analysis, we get a list of our 100 patients back. Well, I call up patient number 1 from that list. Hey, we have a clinical trial that you may be eligible for. Oh, actually, I haven't been to, let's say it's for Oshner. I haven't been to Oshner in 3 months. I moved out of state. Oh, well, I progressed and I'm on another standard of treatment. Oh, well, I can't get a hold of you. And so your list of 100 patients that seems very promising is now getting whittled away. And the effort that you're putting in to whittle away at that list is not really generating any results. And frankly, up until the advent of some of this latest technology, there wasn't really a better way of thinking about this problem. So what the main workflow that we have in today is more of this patient to trial matching workflow. So the idea that we can now, given the scale and given the automation that the platform provides us, is I can take a singular patient and I can match that patient and screen that patient in real time across the entirety of the 1,800 trials at MSK in real time. It is a game changer. Even at the highest level of academic centers that we partner with, not one physician, not one leader could tell us, hey, what percentage of your patient population is really being deeply screened for clinical trials today? That was not a statistic that at any of our partners anyone could give us. And when they did give it to us, they felt that maybe it was 1 in 5, 1 in 4 patients were getting a really deep screen for clinical research. It's a wonder as to why our enrollment rates, are down. And the reason of that is because of all the reasons we mentioned earlier. It's very difficult and very complex and very time-consuming in this day and age to screen patients for clinical trials. And so this is the capability to now say that every time we have an upcoming patient appointment, that's the trigger that our system is using to screen that patient in that moment using all of their medical history for the active population of clinical trials at that institution. And we're doing that in advance of that patient coming in for their appointment. So we can now alert the physician, we can now alert the PI, we can now alert the research manager before that patient comes in that this could be a really strong candidate for a trial when they come in, and I have them right in front of me before we make another treatment decision, before we put them on standard of care. Let's have a conversation about this research. And I think that timeliness is actually the biggest advent of increasing enrollment that we've seen so far in deploying this technology. The last one being here, kind of tracking of ineligible patients. Another area where a lot of patients fall through the gaps. So I have a patient, I go through the inclusion-exclusion criteria. They're missing one criteria. They're a really good candidate for this study, but maybe it's a time-bound criteria. Maybe they have to have been off a therapy for 4 weeks, 6 weeks before they can enroll on study. Well, they're a really good candidate. Let me write down on my sticky note, this MRN, and I'll stick it to my computer, and I'll remember in 3 to 4 weeks to reach back out to that patient because they've become eligible. Unfortunately, that sticky note blows off of the side of your computer, side of your desk, unfortunately a little bit too much than I think we would all like, and tracking down that patient again is a little bit difficult. And so we've kind of built into this system this capability of watch listing patients. So when you see there's a criteria that could change, that could be met in the future, you can flag that criteria, and now the system is actively looking for you on the back end when that criteria changes, and in the moment that patient becomes eligible because we've received new information into that patient chart, alarm bells. I want this notification going to the physician. I want to go into the patient. I want to go in anywhere and everywhere to the stakeholders that can make a difference. And so we're now, again, the timeliness of this information is making an impact when we need it. So how this is played out, again, published a lot on this technology in ASCO, Central Surgical Association. Again, we do a lot of publications with all our partners. Links to these can provide anyone with. They're also on our website. How does this workflow and this technology how has this actually generated results for a cancer center? For those in New Orleans, I feel like Medical College of Wisconsin is actually a really interesting comparator university. So they're an academic center that is associated with a large health system, Frodair Health. They have a very diverse population in Milwaukee, and luckily for us, they were one of our first partners, and a really great case study for how the platform has been working. So this is looking at the first 2 quarters of the deployment in Medical College of Wisconsin. By the end of, on day 1, we were screening 100% of their patient appointments. So 7,000 patients coming into Medical College of Wisconsin every single month. 100% of them were screened automatically against the entire portfolio of trials at MCW. The reduction in chart review time from the end users, the clinical research coordinators, the physicians who were using the platform, nearly 80%. So we did a retrospective and a prospective time-bound study on using the platform and doing manual chart review for some of this work, roughly 25 to 30 minutes in best case scenario for the manual efforts, under 5 minutes with the platform. 72% of all of their trial enrollments for the first 2 quarters that we had the platform in usage came to the platform. So what we think about that is now that's adoption of the platform. So that's quick adoption. So they very, very quickly abandoned their existing ways of enrolling patients. And 72% of all of their enrollments, not net accretive or enrollments, not on top of, all of their enrollments in the first 2 quarters of deployment were coming from the platform itself. And that number has since increased to over 85%. And then the final number, the number that, as a platform, we hesitate to anchor on because I can give as many amazing matches as possible. But there's a whole host of reasons why a patient may not actually enroll on a trial. Socioeconomic barriers, patient just doesn't want to, there's a better treatment pathway. So I can give a million great matches, but trial enrollment is not directly correlated, but it's still a number that everybody wants to hear about. And so in the first quarter of deployment, they saw a 40% increase year over year in total enrollment and a 27% increase in the subsequent quarter year over year. Same size portfolio. And again, this isn't a single trial that we're discussing. This is the entire portfolio of their over 200 studies that saw this 40% increase. We're talking over 100 additional patients year over year that they were able to enroll on study. So that was my spiel on kind of our flagship use case, clinical trial matching. Quickly highlight a couple other things we've been able to do with the same tech stack, data curation and cohort visualization. So for data curation, we think about data curation really broadly. Again, lots of different disparate use cases that data curation could address. So maybe if you're an administrator, tumor registry curation, our federally mandated tumor registries, our state mandated tumor registries that, again, huge amount of manual chart review. They're not assisting patients. We have armies of human manpower addressing them today. Maybe if you're a pharma in the room, you're thinking about all of the real-world evidence that you're trying to generate for future studies and understanding how the treatments in your pipeline are operating. Maybe you're a cancer center administrator and you're understanding, you want to understand better quality metrics. How am I doing on certain things? And I want to ask complex queries back into my chart, retrospective research. So all of these things, again, we believe are enabled when you can fully, deeply understand and query a longitudinal patient record. And so this is a case study here of a large data aggregator and RWD provider in the oncology space that we now have an enterprise agreement with, and all of their data curation is happening automatedly through the platform. And so we were able to say one of the largest projects they had done, they had been quoted from a manual abstraction provider, roughly a 7-month timeline and $1 million to curate a little over 10,000 patients, pan-cancer, for about 100 data elements. That was the standard quote. We were able to get that down to $150,000, and we returned that project in 3 weeks. And the majority of that 3 weeks was making sure that our models were aligned to the specific questions that project entailed. So we, of course, have our baselines, we have our pipelines. Every project has its own nuances. We make those adjustments, 2.5 weeks, and then those 10,000, 12,000 patients were automatically run in less than 24 hours. That's just a scale of compute. If you have compute, you can, parallelize as much as possible. So once you feel like your platform is set up, there is no barrier to how quickly you can solve some of these problems and do it in a much more cost-effective way than manual processes. And in a world where, RWE, okay, that there's commercial on the side, but when we think about provider-facing workflows, tumor registry curation, or other, quality reported metrics, the people probably doing that manual chart review could have much, much better things to be doing with their time. Patient-facing work, understanding other problems within your health system. And so we're really excited about this capability and the broad nature of problems that it can address. And then finally, thinking about what is the exhaust, the output of some of these things that we're doing. So if I'm screening every single patient that comes through my clinic every day for clinical research, and the way we're doing that is by really deeply structuring and understanding that longitudinal record, what am I doing with that information after the fact? Well, of course, we should be interrogating it. We should be using it to our best advantage. We now have the ability to really deeply understand our active patient population. And so we now have the ability, using drop-downs, using simple free text queries, to understand what's happening in our organizations. So, this is kind of how our workflow looks today, the ability using drop-downs to say, before using slicer dicer or some SQL queries, I might be able to understand how many breast cancer patients I have that are on, that have had genomic testing done. Today, we're now able to say, how many stage 4 triple negative breast cancer patients do I have? How many of those are on second line or have completed second line of therapy but have not yet started third line therapy? So when I'm thinking, I'm presented with a clinical trial and I want to know, do I have an accurate patient population? What is my patient population addressability for this research? Instead of having physicians, give their best check feeling for what is happening at the organization, we can really add data and provenance to this workflow. And again, with retrospective research, trying to understand how, being able to identify these patients and say, hey, I want to understand how well we've been doing for metastasized breast cancer patients over the last 3 years. How have we been treating those patients? We can quickly identify those patients, and then we can use the data curation workflow to ask those complex queries of that patient population that we've just narrowed down to. So the ability to do, one of our core workflows, which is question and answer, the ability to, in free text, ask a question to the patient chart, and then structure discrete information as well from that patient record. The combination of those two things we feel can solve many, many problems, some of which have highlighted today, some of which Jason mentioned and are on our roadmap for the future. That's all I have for you. Thanks very much for listening, and I think we'll do some Q&A at the end.